Good evening, Balbir, in Delhi.
Yeah.
Morning in Orlando. We have a full house for you. Welcome to C3.
Good morning, Raj, and it's such an honor to be doing a live case once again to C3. And I hope you're doing well. So we have a nice case for you today. And I would like to have your inputs of the panel as much as possible. So shall we start the case discussions? So I have with me Dr. Binay, who's going to present the case. I have Dr. Brijesh, who's a senior consultant here. And we have the full team, including Mr. Dubey, who's our chief technician. So I request Binay to start the case.
So we have today a 58-year-old lady who is diabetic for 10 years, and she is controlled on oral hypoglycemic drugs. She is hypertensive for 12 years and controlled on ARB and beta blocker. She is obese with BMI of 32.6 and recently diagnosed as Paget's disease of breast, and she was planned for surgery. She is also having angina on exertion for class 2 for past 2 months, and also dyspnea on exertion NYHA2 for past 2 months. She was on guideline-based medical therapy, and despite that medicine, she was symptomatic. She has modifiable risk factors like diabetes, hypertension, and obesity. She has normal lipid profile, no smoking history, and no physical inactivity, and no family history. So coming to lab reports, she has lipid profiles are normal. LDL is mildly elevated, which is 110, and HbA1c is 7.1. Hello, lost the connection. I lost the connection.
We have a connection.
Okay,
keep going.
Okay. So on echocardiography,
we have a connection. You keep talking.
Okay. On echocardiography, her EF is around 50% with hypokinesia of distal IVS, distal anterior wall, and apical segment, and she has mild LVH. On exercise stress echocardiography, her EF fell from 50% to 40%, and distal IVS, distal anterior wall, and apical segment became akinetic. So in ECG, she has ST depression and T-wave inversion in V1 to V3.
So we'll go to the angiogram now. So I will show you the diagnostic angiogram which was done a week back. So this is the left coronary shart done from the radial route. So we have a near total occlusion of the LAD with a long segment which is diseased. Then we have a lesion in the circumflex just before the trifurcation of the two OMs.
Can we see the fluoro screen?
So can you see the fluoro now? Do you see the?
Okay, we see it now.
Okay,
Great.
so this is what was the diagnostic angiogram a week back. So we have a completely occluded LAD. You don't see any distal flow. You have a tight lesion in the circumflex, tight or whatever. There's about 70% lesion in the circumflex before the trifurcation. And we go to the next view, and it shows this LAD is badly diseased and a very faint filling of the distal vessel on the antegrade injection. Next, please. So this is the LAO-caudal view, which does show that the ostium of LAD looks intact, and the ostium of circ is about 3.5. The left main would be about 6. Ostium of LAD looks 3 here. So we will confirm by imaging how this goes. Next, please. So this is the right coronary injection, which has only mild disease and very good collaterals to the LAD. You see the septal collateral going right all the way. Next view. So this is the right coronary injection in the REO projection. You see the septal collateral going right up to the LAD and clearly visualizing the septals, and there should be a moderate sized diagonal right in between the lesion, which we have to take care of, I'm sure, as we go in the procedure. So we have a very big LAD. It traps around the whole of apex, a type 3 LAD, and a lesion in the circumflex. So there we are now. Near total occlusion of the LAD. I think there is a microchannel which may help us, but otherwise we have a good retrograde collateral which is going to the LAD. So this is where we are.
I'm going to pull the panel. Shripal, what would you do in your lab? PCI or cabbage?
So that's a great question, PCI or cabbage. So in patients like this, if you look at the syntax score for this patient, so
we'll
it's
give you
either
the
low
syntax
or
score.
low intermediate. And the second question I generally ask is, can I actually completely revascularize? For me, both the answer to those questions are yes, in which case I would offer PTI for this patient.
Dr. Howda in Germany?
No, clearly we would discuss it in the heart team because it's an elective case, but nevertheless we will go for PCI. We saw the syntax score was 22, so it's an intermediate one. We can discuss it, and the only thing is, can we open the LAD? Yes, then we can make it nicely. If we cannot open the LAD, we send the patient to surgery because the Lima then is the better option.
That's a very fair observation. So based on the guidelines, and Dr. Howda, who is a part of the EAPCI group, just talked about the heart team approach. That heart team approach is beneficial, and the syntax score is intermediate. So if we can fix the LAD, then PCI is a great option here. So what have you done so far, Balbir?
Raj, what would you do to the circumflex? You would leave the circumflex, or you would just open the LAD? That was the question.
I think the circumflex requires a stent. There is no doubt about it. I think that we can argue that we could do an FFR there, but for today, I would say let's fix the LAD and then circ in a stage fashion on another day.
Today. Okay, so we'll show you the first pictures of today. So we have done a contralateral injections. This is epicranial view with a diagnostic catheter in the RC and a guiding catheter 7 French in the LAD. Next, please. And this is a RAO caudal projection showing the same thing. So this circumflex lesion looks like 70% or 60%. So I was a little bothered, and the patient wants both the things to be fixed in same sitting. So, but I was concerned whether I should do it or not. So first thing I did was took an FFR wire, next please, onto the circumflex, this is the wire to the circumflex, and we have an FFR. Can you see the FFR? 0.68.
I do not see the FFR screen.
We'll show you.
Yeah, so FFR 0.68.
Yeah, 0.68 is the FFR, so that makes me believe that we have to do it. So now the question was that I want to do the LAD first, so I left the FFR wire in the OM and took a Fielder XT with a crosshair to get into the LAD. Next, please. So there was a micro channel. Can you run? So there was a micro channel with the support of a crosshair. You can see the crosshair behind that. We were able to make some good progress a little slowly, and this is showing an RC injection that the Fielder XTR wire is in the true lumen. And now we also see the diagonal lighting up.
Fantastic. Yeah. So this is exactly how the case should be done. FFR of the circ and crossing the LAD.
So now we have the crosshair. Next, please. So I crossed with the help of a crosshair, got the Fielder XT wire down, and then drilled the crosshair distally. Next. This took some effort, getting the crosshair, drilling down the LAD, and then I exchanged to a BMW wire, pulled out the crosshair by holding the wire with a 2.5 millimeter balloon in the guiding catheter. So I'm at this stage with you. We have the OCT imaging ready, we have the balloon ready. I'm going down the LAD with the balloon now. So any opinion or any change of strategy?
I would recommend that we balloon angioplasty the LAD and then do the OCT run so that we have better images.
Exactly this is what I'm going to do.
This is just too significant, and we won't be able to clear.
I agree with you.
That sounds like a great idea, because otherwise we're not going to see much.
Okay. 3, 4.
So Dr. Balbir is at the Medicity Institution in Delhi and has the highest experience for OCT in India.
Yeah,
so it'd be great to see the OCT run.
12. Yeah, I would love that we get a good image for you today. 14. Down. 14. 16. Down. So even though I had drilled with a crosshair, I would not have got any great images with OCT if I had not dilated. 6, 8, 10, 12. 14. Down. NTG 14. Down. 14. Down. OCT catheter.
There's definitely some opportunity for improved medical therapy for this patient. You know, the LDL is 110, and we have had a lot of discussion about, LDL reduction in this type of patients with diffuse coronary disease. At least in our practice, we would put this patient on PCSK9 inhibitors. I don't think that PCSK9 is just yet available in
No, it
India,
is available
but I think
now.
it's supposed to come very soon.
It's available.
Dr. Pathak is in the audience. I'm sure she'll tell me. Coming, yeah.
Yeah, I think the other important point is it's always tempting to go after the easy lesion, but it's always better to go with the plan. And I mean, this CTO, this is a near total occlusion with a channel, which JCTO of like very low. So it was an easy CTO, but it's always better to go with the plan saying we go after the CTO lesion if you fail so that you can actually bypass the patient rather than going after your simple lesion.
Now, Goran, in terms of stent selection in bifurcation where you have multiple branches, clearly there is some impact of stent design and the link in bifurcation disease. Do you have any preference of stents, about which stent would you use?
As I said, unless in case of probably distal left main with very large circumflex, where you really need to have probably preferably two-link design. All the rest, I think, will allow you full access with currently available DES, whether it's three-link or two-connector design. That doesn't make a big impact. It's just evaluation based on the bench testing data, but was never proved actually in real clinical scenario.
Never pull back.
Dr. Howda, you have a lot of experience with Negmaris, which is the next generation bioresorbable platform. Would you think this LAD would be a good case for something like that?
Well, currently we don't recommend to do it because this is more or less a CTO lesion, so there will be excessive plaque burden. You need to do a super good lesion preparation, which probably will not be good enough to sustain the rate of strength of any kind of absorbable device currently. So we don't recommend to do that. So we would use here a modern drug-eluting stent, which accommodates the whole length there. And
great point.
I think that's the way to go for.
Great point. Can you make the OCT screen bigger, and I will interpret the OCT for the audience?
Yeah, please make the OCT bigger.
Fantastic. Okay, good. So I saw a lot of diffuse disease. The whole vessel is really studded with fibrotic plaque. I did not see a lot of calcification in this artery.
शुरू से दिखाओ, beginning.
And because there is so much disease and the flow is not that great, there is some contrast artifact in this image.
2.548.
But I think we can see enough.
2.548. Can you measure the diameter and the distal part? Okay.
Yeah, I think that EEL to EEL, even if we take such a generous measurement, it's going to be somewhere in range of 2.3, 2.4. So 2.5 stents is good.
So we are taking
for
a 2.5 into 48 Zion's expedition. Check the proximal diameter.
So one of the advantages in India is that the 48 stent is available.
A little bit. The disadvantage of the OCT in this tight lesions where you don't get it cleared very nicely. So I'm still an old-fashioned guy in that and prefer the IVUS that allows you a little bit more to have an in-depth insight into the vessel wall, which is here difficult to achieve.
Yeah, I think that, at times when the vessel is diffusely diseased and there is not a great flow, sometimes you do get a somewhat suboptimal image. But I think it's enough to give us the information that we are looking for. especially if the vessel was quite calcified. I think that the OCT would be extremely useful in potentially changing the therapy, because if it's highly calcified, then we may consider doing a rotational atherectomy, which would be somewhat of a limitation with IVUS, because all we are going to see on the IVUS is a bright shadow in reverberation from heavy calcification without assessing really the thickness or the circumference of the calcium. So I still like the OCT, but clearly this is one of the things that happens with this really diffusely diseased vessels. Now, there are high-definition IVUS available now, and they might have some advantage here in terms of proper delineation of the diameter.
If I may just share part of the routine clinical practice, we use imaging more for optimizing results than just to evaluate initially after recanalization the anatomy. And after full predilatation, I think based on experience, more or less, if there is no really extensively calcified vessel, you can decide
it and then do it.
And then do IVUS or OCT, whatever is your preference.
I think which is very fair in this situation to do it that way. So, Balbir, have you placed the stent already? Can we see the fluoro now?
Yeah, I have placed a 2.5 48 stent, which is Zine's expedition. So we deployed at 12 atmosphere, then I pulled the balloon back to go to 18 and dilated the rest of the lesion with the same balloon. And now I'm going to take a picture and then probably another OCT run to guide me to the ostium. Now the flow is much better, so we will have a better view on the ostium and the OCT. So I'm sure we'll be able to be guided. From the previous view, the LED seems to be 3 millimeter. So we'll just have a look at the left main also in this view. And then I will guide my stent based on what dimensions I get on the OCT. Now I'll get a good OCT image now that the flow is restored in the LED. And then we go ahead and optimize this.
It looks great in comparison to what we started with. It's a great case. Great case. I think we have enough time. We may even have you put the stent in the circ
Let's
today.
hope so. So I leave it at that because I want to visualize the proximal part.
Oh, you're so efficient and good.
Okay, so
Dr. Howda, one more question for you.
Pull back.
In terms of the strut thickness, you were involved in a lot of studies with Orsido, which is a super thin strut DES.
So we can have
do you think that in terms of long-term clinical outcome with this long, very long stented segments, diffuse disease like this, a super thin strut stent may have an advantage in terms of healing?
No, I totally believe, because I tried to convey that in my presentation, is that it's much easier to not only oppose the strut, which is thin, but also to embed it, and you get a faster endothelialization, coverage, exclusion from the bloodstream, so the thrombotic effect is going to awake much, much earlier. And also the aspect of late near-atherosclerosis, which has to be shown, could be to some extent more beneficial because you have a more beneficial ratio of metallic coverage on the surface of the artery than you do have with thicker struts. But currently, I mean, a thin strut or ultra-thin strut device usually is in Germany the way to go for.
Okay, we have the OCT. Can you see the OCT image? We'll start from the beginning. Can you run from the beginning, please?
Yeah, we see it perfect. It looks great. The distal stent is well expanded. There is a proximal edge dissection. So we know that we need to put a second stent in. So we just need the length and the diameter.
Yeah, right. So I will choose the length and the diameter based on the OCT because that will help me really put it right exactly at the ostium. I want to avoid the left main because there is no plaque in the left main. We'll show you what we have seen on the left main and the LED. So there is some work to be done in this part of the stent, which I will do.
Yeah, needs a post-dilatation with a 3O balloon.
Yeah,
I was just about to talk about stent MLA. So in iLumen 3, actually in European consensus document for OCT, the final result post-stenting requires 80% or better MLA in comparison to the average reference lumen. However, in iLumen 4, which is a trial that's ongoing now, requires more than 95% of the MLA. And we find that it's very difficult to achieve it, especially in patients, those who have calcific disease, to get 90% plus MLA of the reference in real life. So I think that this result looks fabulous by OCT.
So I'm taking a 320.
So what you are seeing on the screen is also a longitudinal view where it's you see a stent rendering. All the white struts shows proper apposition. If there is malapposition, you will see red, and that's a very easy way to pick up malapposition. Now, malapposition and under expansion are two separate things, and that's why you sometimes should scroll through these images to make sure that there is full expansion. So there are a couple areas within the previously placed stent where a small degree of post-dilatation would be useful, but this is a great advantage of this new software that Dr. Balbir is using.
So I'm using to 3 into 23 Alpine.
So this is a 3.5 or a 3.0?
3.0 stent, 323. We got a diameter of 3 on OCT, and we got a length of 19 millimeters. So I'm using a 3 into 23 Science Alpine. I will post dilate with a 3.5. I'll post dilate the
Okay, great.
And then take an OCT actually. Go up, 12,
Great.
14, down. RO caudal, double mag off. 14, 16, down. 14, 16, 3.5 balloon.
So he's going to use the implant balloon for post-dilatation, not a non-compliant one.
Yeah, but I think I've seen the lesion, it's very soft, so I can do that. I can save on a cost of a balloon for this patient. 14. Down.
And Zayas delivery balloon.
Yeah, you know, it's going to be cost conscious because the patient pays for all of this equipment. So
3.5.
it's pretty common to try to think through the case that how we can save a couple bucks to save this
And
patient.
Zayas delivery is one of the most compliant delivery platforms, so he can go really to very high pressure.
Yeah, you can go at high pressure and expand the stent. Yeah.
Expand the stent.
Yeah, I think it's also critical if you're not using imaging routinely, especially for these long stents, to routinely post-dilate.
So, Dr. Balbir, what is going to be the post-procedure DAPT regimen for this patient and how long?
So she is on clopidogrel and aspirin, and we would love to continue it for at least 1 year or maybe much longer, because I am quite convinced that in such long lesions, the longer you give, it's better for the patient. 16.
Yeah, so yesterday evening there was a paper presented by Mark Bonaca from Harvard looking at the complex stenting and duration of DAPT. And in his analysis, he showed that the patients benefited for at least 30 months of therapy. So in a simple case versus a complex case where there are multiple stents implanted, the outcome may be somewhat different, you know, and the DAPT duration may have impact on what happens to the stents.
So I think we'll show you the OCT run before we go offline. I think we are post-dilated the LAD quite well with a 3.5.
Yeah, so in our lab we do angio and OCT at the same time. So I would like you to do the same thing.
I will never
do angio
I
and
will do
OCT
the
at the same time. We don't need any other injection.
Right, so that's what I am going to do. So I will take the OCT catheter, and I have few minutes, I'm sure, to show you the OCT run.
Yeah, we have time for the OCT, no problem. So Dr. Balbir is a superb operator. He's done a lot of cases. I've had the privilege of being at his center many times. He's done a great work in Delhi.
Thanks, Dr. Dave. It's your encouragement and your support always there with us.
So important thing is that, there are 3 markers on the OCT catheter. The most distal marker is the delivery catheter, and there is a proximal lens marker. So we want the second marker beyond the stent so that we can look at the distal edge. 3 things that, change the outcome of the stents is edge issues such as edge dissection, implantation of a stent in a very heavily plaque burden vessel under expansion, and improper sizing. So I think that this is good. So I don't see edge dissection.
So we can have the run, please. Okay, can you run, please? So this is the distal part of the vessel, and there's no edge dissection. It smoothly goes into the stent, very well expanded. And we see the 3 millimeter balloon has made a much bigger lumen area than what it was. We're going to do the calculations later on, but it's much bigger than what we saw in the previous shot. And here I probably may go with a high pressure balloon at this point. We'll calculate the MLA to see if I need to do that. And it looks pretty smooth thereafter. And as we go to the proximal part of the stent, it's again quite good. And we saw the diagonal coming through, flying through, and looked all right. We can see that in the 3D view. And now we have to visualize the ostium. The MLA seems to be pretty good. They can do the calculations right away. So I'll take the ostium now. I have to pull back the catheter a little bit to take a ostium view. So can we do another run? We can do aleocaudal. Enable. Start. Okay, so the ostium looks quite good. So we'll see that again on the OCT. So there is just malopposition of 1 strut or 2 struts in the left main, which I don't think I'm going to chase because I won't be successful. The left main diameter is about 5. And I have post dilated with 3.5. We are coming close to the ostium, and here is the ostium, and this is the circumflex, and this is the malopposition that you see in the left main. I won't be able to handle that because left main diameter is about 5, and this is about 1 millimeter of malopposition. So what do you think, Raj, there?
Yeah, I just wanted to see that picture.
Can you show the picture? Can you show the angiogram?
So it's a fairly large arc of the stent struts. What I recommend is that you take a 4/12 balloon and just dilate at the ostium into the left main, and that is going to make this significantly better.
Yeah, I can do that. 4/8.
It's just few struts extended into the left main. I think a 1/4 dilatation will improve these. Yeah.
So angiographically, it looks nice. And after this, I'm going to chase the circumflex and finish.
Yeah, it looks great. Yeah. I think that with a 4 dilatation, this will be just fine. Yeah.
I think this is a great example. If you were just doing angiography, you'll think it's great, right? I mean, the OCT only shows that you have a couple of struts in the left main, which is hanging.
So I've chosen a 4x8 millimeter balloon, little more RU. So we're going to use the clear stent view to decide.
Yeah, I think if you are a little bit inside the LED, I think it's going to be just fine with this balloon. So yeah, no problem. Yeah. The LED is large enough.
Chalo, go 10.
Well, we're going to lose you probably in about 10 seconds here. So I want to thank you for a great case.
Thanks, Raj.
Very instructional and a tremendous job.
14. Down.
And look forward to having you at C3 many, many times again.
Thank you, Raj. Thanks a lot.